Welcome, viewers. A scientific seminar on cardiovascular diseases was held on 3rd September in Community-based Medical College Hospital, Gallery number 1. Department of Cardiology presented in this seminar. Director of the hospital, Community-based Medical College Hospital, Professor M. Karim Khan presided over the seminar. Principal Professor Dr. Mahfuzur Rahman Khan Chaudhary was chief guest of this seminar. Please watch the recorded part of the video.
Bismillahirrahmanirrahim. Honorable Chairperson, Honorable Principal Sir, respected teachers, and my dear colleague, Assalamu alaikum. I am Dr. Parvez Rahman Khan, Junior Consultant Cardiology Department. Now, with the permission of the Chairperson, I am going to present my topic. Today's my topic is pregnancy with hypertension. So, when we will call hypertension, if the diastolic blood pressure more than or equal to 90 mm of mercury and systolic blood pressure more than or equal to 140 mm of mercury, or an increase in the diastolic blood pressure more than or equal to 15 mm of mercury, or in the systolic blood pressure of 30 mm of mercury as compared to previous pressure. The increased blood pressure will be present on at least two separate occasions, at least 6 hours apart. So hypertension is one of the most common complications during pregnancy. It increases the maternal and also paternal morbidity and mortality. It is a sign of an underlying pathology that may be pre-existing or appear for the first time during pregnancy. That is why it is also called as toxemia of pregnancy. Incidence 6% to 8% of all pregnancies. It complicates 10 to 20% of pregnancies. Now the risk factor, preeclampsia in previous pregnancy, age more than 40 years and less than 18 years, family history of pregnancy-induced hypertension, chronic renal disease, antiphospholipid antibody syndrome, or inherited thrombophilia, vascular or connective tissue disease, diabetes mellitus, it may be pre-gestational and gestational, multi-fetal gestation, high body mass index, male partner whose previous partner had preeclampsia, and hydrops fetalis. Classification: there are chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and preeclampsia superimposed on chronic hypertension. So in chronic hypertension, we can call hypertension present pre-pregnancy or before 20 weeks of gestation. And gestational hypertension, new onset hypertension after 20 weeks of gestation without significant proteinuria. Preeclampsia, eclampsia, new hypertension after 20 weeks of gestation with significant proteinuria or evidence of end organ damage. Preeclampsia may be present with severe feature and preeclampsia without severe feature. And when preeclampsia is complicated with conversion, we will say it eclampsia. Preeclampsia superimposed on chronic hypertension. Women with chronic hypertension, it may be primary or secondary, who develop preeclampsia. Hypertension affects 5 to 15% of pregnancy. It itself a matter of concern. So, if hypertension present before 20 weeks of gestation and if proteinuria is present, then it is called chronic hypertension on superimposed eclampsia and preeclampsia. And if no proteinuria is present, then it is called chronic hypertension. And hypertension occurs after 20 weeks of gestation. If proteinuria is present, then it is called preeclampsia. And no proteinuria is present, then it is gestational hypertension. According to the severity of hypertension, we can classify mild, moderate, severe. Mild, when systolic blood pressure 140 to 149 mm of mercury and diastolic blood pressure 90 to 99 mm of mercury. And moderate, when systolic blood pressure 150 to 159 mm of mercury and diastolic blood pressure 100 to 109 mm of mercury. And severe, when systolic blood pressure more than or equal to 160 millimeter of mercury, and diastolic blood pressure more than or equal to 110 millimeter of mercury. We can do some laboratory tests like urine test, urinary protein, dipstick, and 24 hours urinary protein. Blood test, we can do renal function test, serum creatine, urinary albumin, liver function test, AST, ALT, alkaline phosphatase, coagulation test, prothrombin time, plasma thromboplastin time, INR, fibrinogen, CBC, ultrasonogram, and other investigation depending on the organ involvement. We can do ophthalmology, echocardiogram, ECG, and also CT scan of the brain. Complication of hypertension in pregnancy for mother: eclampsia, blindness, blurring of vision, intracranial bleeding, heart failure, pulmonary edema, hepatic failure, rupture of liver, renal failure, abruptio placenta, and even death. Complication of hypertension in pregnancy for fetus: preterm birth, IOGR, and IUD. Treatment: general and medical treatment, bed rest, diet salt restricted, antihypertensive medication, observation and regular follow-up, close maternal and fetal monitoring. So, in case of mild to moderate hypertension, that is, if blood pressure is less than 160 by 110 millimeter of mercury, we can use methyl dopa. It is a drug of first choice, proven safety record, do not alter the maternal cardiac output or blood flow to the uterus or kidney. We can also use levodopa. It is also considered as first choice, safety similar to methyl dopa, rapidly acting, oral or IV form can be used, don't alter the maternal hemodynamics. In case of severe hypertension or hypertensive emergency, that is, if blood pressure is more than 1 or equal to 160 by 110 millimeter of mercury, hydralazine can be used, IV hydralazine. We can also use nifedipine and sodium nitroprusside if all the agents are failed. Methyl dopa is used 250 milligram VD or TID. Maximum use is 3 gram per day. Levodopa 100 milligram. Maximum use is 2400 milligram per day. Nifedipine 30 to 60 milligram. Maximum use is 120 milligram per day. So ড্রাগগুলোর নাম মনে রাখার জন্য একটা মিনিমারিক ইউজ করা যায়, এটা বলা হচ্ছে হার নিউ ল্যাব, এইচ তে হাইড্রোলাজিন, এন তে নিফিডিপিন, এল তে লেভিটলল, অ্যান্ড এম তে হচ্ছে মিথাইল ডোপা. Some drugs are contraindicated in hypertension, like ACE inhibitor and angiotensin receptor antagonist. So outline of management of preeclampsia: antihypertensive agent use. Project aim of blood pressure reduction less than 150 by 80 millimeter of mercury. First line levodopa, oral or IV. Second line methyl dopa, nifedipine. Monitor of blood pressure every 4 hourly. Hourly if severe preeclampsia. With management and delivery. Only cure is delivery. Hospital delivery is must. Depending on the condition of the mother and fetus, termination of pregnancy is needed. Type of delivery: vaginal delivery and cesarean section due to obstetric cause. Prevention: there are some preventive measures we can take. Risk factor like risk factor determination, antiplatelet agent can be used like aspirin for risk patient, calcium supplement, and regular antenatal checkup. So hypertension disorder in pregnancy is one of the most common cause of maternal mortality in Bangladesh. It also carries risk for the baby. So knowledge about hypertension in pregnancy and its management, it is very much necessary. Regular follow-up, risk determination, necessary investigation, and proper management in proper time should be done to avoid complication. Thank you for patience here.